Dear Chair, dear audience, my PhD thesis is about developmental defects of enamel, etiological aspects, and clinical management. My name is Mlinkó, and working at the Department of Pediatric Dentistry and Orthodontics. My vision as a PhD student is to improve the life quality of children with different enamel defects for better clinical assessment. My mission is to discover causes of these enamel defects and finding new intervention protocols that improving pediatric dentistry. To achieve these missions, these two ongoing projects are my specific goals about the etiology of different enamel defects through certain risk factors, and I will explain them ahead. My first project is investigating different types of antibiotics at early childhood as risk factors in molar incisor hypomineralization. The abbreviation of it is MIH. I will use this from now. So MIH is affecting the first permanent molars in the incisors. This is the most frequent enamel disturbance with the global prevalence of 13.5%. The etiology is still unknown. What we already know is that the amelogenesis of the affected teeth are at the same chronological time. Many putative factors are listed in the literature, and also we know the harmful effects of tetracycline on enamel defects, but there are less knowledge of the effect of other type of antibiotics. So our aim is to evaluate the strengths between early childhood antibiotic intake and MIH. Our question is, does early childhood antibiotic intake increase the risk of MIH? Our question framework is a PO with the population of children aged 6 till 14, which is the most validated time for the diagnosis. The exposure are the different type of antibiotics, and the outcome is the molar incisor hypomineralization. Our hypothesis is that the early childhood antibiotic increased the risk of MIH. And our implication is to understand the causative mechanism of developing this enamel defect. In our systematic search, we used in 3 databases these 2 different domains. And in the flowchart of selection, we ended 36 full text and added additionally 5 studies from the citation and manual searches. Our outcome is the molar incisor hypomineralization, which is causing severe hypersensitivity, posteruptive enamel breakdown, and it can lead even to tooth loss. The outcome measure is odds ratio with 95% confidence intervals. All of our finished analyses are about the risk assessment of antibiotic exposure in MIH development. We investigated the general antibiotic exposure, the prenatally taken antibiotics, and 4 different types. The first figure is about the general antibiotic intake in early childhood on MIH development, where the outcome is MIH. Our population were children who were MIH positive or negative with the antibiotic exposure at early childhood. This time means the first 4 years of life when these teeth are under development, and any putative factors can negatively affect the enamel development. We compared them with the control group who were non-exposed to antibiotics. The total population yielded to more than 20,000 patients. We could include 27 studies. The study designs were case control and cross-sectional designs, which we could use in the subgroup analysis. In our heterogeneity, it ended with 47%, which is moderate. It can be due to the reason that we had low information about the antibiotic intakes, for example, the dose or the exposure. The result is 1.50 odds ratio, which means that the odds of developing MIH is 1.50 higher with antibiotic intake in early childhood, which clinical implication is that we need to reduce the inappropriate use of antibiotics, although we need to interpret this result with caution due to the retrospective study designs, and the data were based mainly on mothers' questionnaires. We investigated also the most common types of antibiotics, amoxicillin and penicillin, with the same population. So they were children with MIH positive and negative children. The total population were high, mainly in the amoxicillin group, where we could only include 6 studies in the amoxicillin and penicillin analysis. Also, the subgroup analysis in the study were the study designs, which were case control and cross-sectional studies in both analyses. The heterogeneity level was high in both groups, higher in the penicillin intake analysis, and the odds ratio were 1.87 in the amoxicillin population, 2.15 in the penicillin population, which show us a high association of antibiotic intake to early childhood in the development of this enamel defect. We also investigated the prenatal antibiotic exposure effect on MIH development, where the population were the mothers of these children who were taken antibiotics during pregnancy time, and also the control group who were non-exposed to any type of antibiotics. We could include 4,100 patients and case control and cross-sectional study designs. The heterogeneity level becomes 0 because of the low number of studies. The final odds ratio is 1.17, which shows us that the association is lower in the prenatal antibiotic intake than during or after birth. The strength of our study is that this is the first meta-analysis assessing different antibiotic types and MIH with a high population number. The limitations are that these observational studies cannot establish a strong cause-effect relationships for etiological factors. The low number of studies which investigated the different antibiotic types, and our prognostic factor, the antibiotics, have unknown details, for example, recurrent or single use, and the hidden disease for what it was used for. And so the data were based on questionnaires. Mainly only 3 studies used medical records. Our conclusion is that early childhood antibiotic intake is associated with MIH. Our implication for practice is to avoid inappropriate antibiotic use, and the accurate medical documentation are needed. The implication for research are the preclinical studies suggesting harmful effects of antibiotics in the mineral content of the teeth, but current literature data didn't reveal a clear cause effect between the antibiotic use and this enamel defect. So these studies should aim to understand the causative mechanism of action in the development of molar incisor hypomineralization. The current status of our manuscript is now it's under internal review. And this is the first project progress. And now I would like to introduce the second project, which is investigating vitamin D status at early childhood on developmental defects of enamel. Developmental defects of enamel can be qualitative or quantitative disturbances with the same prevalence rate in primary and permanent dentition. The amelogenesis starts 16th week of intrauterine life and ends around the age of 5. The mineralization process starts in the primary dentition at the 3rd trimester and after birth at the permanent dentition. The vitamin D plays an important role controlling the plasma calcium and phosphate concentrations during enamel mineralization. Vitamin D deficiency have a global prevalence of 15.7%, and if it occurs, it can lead to bone deformities like rickets or dental developmental problems. In this histological picture from a mandibular mouse incisor, we can see the upper picture where the enamel is healthy, and the lower picture, letter E, shows the enamel, where the vitamin D deficiency caused much weaker structured enamel. But we have lack of strong evidence in the literature, so our aim is to determine how vitamin D serum level influence the dental enamel development. Here you can see our preliminary research for 3 databases and with 2 different domains. Our clinical question is that what is the consequence of vitamin D level to the dental enamel development? Our question framework is a PO with the population of children and their mothers. The exposure is the serum levels of vitamin D deficiency, and the other exposure is the vitamin D supplement pre- and postnatally. The outcome is any type of enamel defects. The hypothesis is that increase vitamin D level, decreasing the risk of development of enamel defects. Our implication is to recognize opportunities for prevention. The topic is feasible, and for summary, we would like to submit our first study in February, and the second is planned in July. I would like to finish my presentation with this quote: "The aim of science is not to open the door to infinite wisdom, but to set some limit on infinite error." Thank you for your kind attention.
What do you suspect the problem could be in enamel development when antibiotics is used? What is the mechanisms behind? Is there any speculation on that, or?
There are, in the amoxicillin, we have some animal studies result where they, in certain parts, they stop the ameloblasts work. So there are problems in the mineralization process mainly. But in human studies, we couldn't have this examination, and the problem is with the studies that we can see only retrospectively because of the enamel development starts earlier than we can detect it in the oral cavity.
The second study you mentioned about the D vitamin, I didn't completely understand that what is the A2, so the second group, which is consumption of the vitamin. Do you want to compare those group with those one which has not any consumption or supplement?
One exposure is if they detected the vitamin D deficiency in the postnatal time, and the other is if the mothers have taken prenatally D vitamin supplement and the children have taken. So it's two separate things. One, there are different studies. Studies are investigating the vitamin D deficiency, and there are studies who have seen that if the patients were having a supplement and how
but those patients has the deficiency who has a supplement, because that would make sense that if I recognize a deficiency, I recommend the supplement. So that's why I'm a little bit confused that how these two groups come together, because there are patients with vitamin problems, absorption or in blood test. And also this is another question, because this is drive to another question, that even if you take the vitamin per dose, you might have deficiency because of absorption problem, as far as I know. So that's, I would a little bit clear this up. Or maybe you need several groups, like healthy patients with normal D vitamin level and supplement, this is the second group, and deficiency and supplement. So basically these four groups.
Yes, maybe that was a bit misunderstandable. The plan is to compare, so to have the vitamin D deficiency group and the healthy group who get a supplement, and then if we have enough information, check which level of supplement was enough. Because in the guidelines, automatically we give for the children the vitamin from birth, and we could compare this with the ones who get no supplement, and what was the result regarding to the enamel defects.
Okay. Thank you.